In the Name of Overhead Athletics podcast, where we cover rehabilitation, biomechanics, human movement, and optimizing human performance. Max Wardell from In the Name of Overhead Athletics here. Today I have two guests, Scott Richardson, Rich Rehab, and Nolan Rappé. Nolan is a physical therapist, specializes in the overhead athlete. He has a lot of great material he's putting out online. We got into some discussions. Rich Rehab, Scott Richardson was on those discussions. He's a physical therapy student, works with a lot of baseball players, does quite a bit of cool training, puts out a lot of great information as well. And we got into a great discussion on shoulder arthrokinematics and how the shoulder moves, and then how we should try to regain motion, or what we should do in our assessment to look at motion. And I wanted to get these two guys on the podcast, talk a little bit about that, and then also talk about some other things in the fields of rehabilitation and training of the overhead throwing athletes. So welcome guys.
Yeah. Thanks for having me.
Yeah, so just to continue on our discussion, for anyone who hasn't seen it, we were on Twitter and we were just, having a nice little debate on shoulder internal rotation, which has become, a popular topic, especially in blog posts on social media regarding, all right, how do we assess motion? Is it total range of motion? Is it just your internal rotation range? And I know you guys have some interesting thoughts on that, as well as how do we start to, regain motion in somebody who actually does have a real deficit in motion. So why don't you kick us off, Nolan, and kind of give us some of your thoughts, as well as, what your practice includes as far as the internal rotation of the shoulder goes.
Yeah, so obviously we still get plenty of referrals to us where we have that kind of GIRD diagnoses, right? And so the first thing we do is we educate the patient on what we feel like is important, right? So when they come in with that diagnosis, we make sure that they understand that it is more about that total motion of the shoulder, and that there are even some motions that we would prioritize even over just simply cranking them into internal rotation. The biggest thing that I see as a limiting factor is obviously not really the internal rotation aspect. It's a lack of external rotation when it comes to the total arc. MoCap has kind of changed our opinion of how much actual internal rotation that we may need in a more efficient throwing pattern. So it's a huge education piece coming in and kind of trying to help the patient understand, listen, you're not broken because you lack internal rotation. In fact, this is a normal range of motion for you as an overhead athlete, as a thrower, to not have what we characterize as full. And then obviously we measure their total arc, measure their shoulder flexion, which is exactly kind of the part of the conversation that sparked probably the desire to kind of have us on is if we felt like shoulder flexion was something that we needed to measure and prioritize in clinic. But yeah, we'll take a total arc look at the shoulder. Obviously, your scapulohumeral kinematics are obviously a massive part too. But I would say most of the time that we prioritize changing shoulder internal rotation, range of motion, and quality of that range of motion through soft tissue work. And it's like you were saying in our conversation, we're probably greater than 75% of our issues with shoulder internal rotation are soft tissue restrictions. I loved what you touched on about just the inferior lobes and things like that, because I don't think that's something that a lot of clinicians would go to immediately, or if they did go to joint moving, I think they probably are getting somebody up in that 90-90 position and cranking on them almost in that sleeper stretch type position. And I would rather obtain shoulder internal rotation, again, more from the soft tissue work, and then working on like horizontal adduction, range of motion, things like that. So that's just some of the thoughts that I have when I have somebody come in with some issues with shoulder internal rotation as part of that total arc of something that we want to address. And again, like I said, I would more apt to address the lack of external rotation first, or if they have external rotation and can't control that actively, giving them total arc control, through the whole range of motion, than to just immediately spend a bunch of time cranking it internal rotation.
What are you doing to work on the external rotation, range of motion? Like, say you feel like, man, this guy he either doesn't access it in his throw the way you want him to, or just doesn't have access to it even passively the way you want him to. What are your kind of go-to things, and how are you starting to regain that? Because I know we'll see all sorts of apprehension in those positions. I mean, you can easily take that guy out into a little bit more of the scapular plane, but what are your go-to things there?
Yeah, I mean, given where they're at in shoulder external rotation in the actual motion, I always like to try and get them comfortable in some horizontal abduction with external rotation as quick as we can. I think that just bodes well for a quicker return to our throwing programs. So I like to go from, again, those positions of the most basic support, so you think prone quadruped, and then work our way up into your various, tall kneeling, half kneeling, standing, split stance, those type of things. I will admit I'm not a huge, from a position standpoint, I'm not a huge single leg stance guy with a lot of the stuff that we do. I like split stance a lot, and that kind of stride position. I mean, again, it's personal preference. I don't think that you're wrong to do a lot of single leg stance stuff with our pitchers, but I don't prioritize that as a position that I feel like I have to get them into. But from a shoulder perspective, to me, getting them in prone, having them restore the quality of the motion, first and foremost, is the first thing that we do. And then I like a lot of the doorway stuff. So we'll get them in split stance, have them get on the doorway, and then control a nice slow lift off, little isometric hold at the end, then come back on, eventually get them into
It's like
prone
an
to do that.
isotonic. Are you talking about like an end range, like isotonic liftoff type of thing?
Correct.
Okay.
Correct. Yeah. Well, again, with a little iso hold at the end, and then get them in prone. Gravity's going to hit them. So prone, do the exact same thing. I start with the hand elevated on something like an RX pad, elbow on the ground, have them control that liftoff. You can load it. I know there's some like FRC positions where they're down almost in all fours. Arm up on the box, same idea, getting them to control that end range motion. I'm big on some of the long axis rotation stuff. You've probably seen like some of Zach Dacan stuff where he gets them out here. I know you can't really see me very well. He gets them out at that kind of 90-90 position. Yeah, and you cue them to control from the shoulder, that the shoulder moves. I always kind of use like an external cue. The shoulder moves the thumb, back and down through that full range. And then that also becomes something that we then control shoulder internal rotation through as well. So you can have them do it with like a slider on the wall. And then you can also, for the external rotation aspect of it and the internal rotation, you can have them use a strength band. In clinic here, I'll just hold the other end of the strength band. It's anchored in on one of the implements that we have here in clinic, and then they control that full arc motion from the shoulder. Because I think we get very biased on 90-90, and I think just overall general shoulder health, I like to get them in other positions to control a total arc rotation and just bias different positions of the joint.
Yeah, I like that. Where you at, Scott? Where you at with all this?
Yeah, I mean, I think I agree with a lot of that. And with where I'm at as being a PT student, I'm seeing guys kind of on the performance side of things. So a lot of times, they just finished up PT. They're coming to me because, being a PT student, having a little bit of knowledge of what's going on in that realm. Then I'm kind of just, progressing from like where a lot of the stuff where Nolan was doing with them, and then, continuing to build off of it, but now starting to add a little bit more load. In some positions like, going from a lot of those end range liftoffs to now, okay, can we like load up like a cable chest fly, just nice and controlled into that eccentric, really just beginning to teach them how to, get full length of the pecs load into that fully lengthened position that they're going to get to in the throw, and giving them some stability of the cable column itself, as opposed to using like dumbbells. And then just really focusing on quality of movement. You know, a lot of my guys are remote, so I'm not able to get my hands on them, but so really focusing on the soft tissue, the quality of movement. And then, if they're really lacking a lot of those things, I'm really looking at pec length, lat length, as they kind of go along. And especially once throwing begins to ramp up and higher intensity stuff, making sure that we're not taking those steps back and beginning to lose it, as some of those muscles, can get a little bit tighter from the demands of high intensity throwing.
Yeah, when you're looking at external rotation, I mean, both of you guys, what I'm looking at a lot of times is I'm seeing external rotation limitations as a result of shoulder, and I end up getting people that are probably, I don't know, failed other times. That's a large percentage of the guys that I see. I actually have a guy on my schedule right now that went through like 3 months of PT, basically used up all his visits until this new year kicked in. Slap tear. His brother is an orthopedic surgeon, and found out about me and sent him over to me. But failed these other methods. He has very limited external rotation in his throw, and it's because he can't tolerate the position. And so I have to get him way out in front of his chest when he throws, and he's way out here. And so he's a pushy arm action. Someone might tell him, like, dude, don't push the ball so much. But it's like, he just can't tolerate it back here. And I can take him passively into the motion as long as I give him like an anterior superior presence and give him like a posterior inferior force. So that's the only way I can get him to tolerate it. And I think you touched on something great, Scott, which was like the progression of exercise. We need to start loading into these motions. And one of the things that I see, and he's been through 3 months of PT, and I don't know how weak he was to start that, but when somebody comes to me after going through 2 months of therapy or 3 months of therapy, and they're still really weak in the rotator cuff, that's an issue. And I find that sometimes we don't actually progress. Like, it's sometimes just take a few exercise, progress the load, and get them a lot stronger instead of throwing these really cool, fancy looking exercises at guys. But, I guess this multifactorial question here, which is, what are we doing in the case of, these guys that aren't really tolerant to that external rotation position? And then, once again, like, what are you guys doing as far as progressing exercise to really get them back to full strength? Because we see it missed all the time. Whoever wants to take that one off.
I guess I can start. I think it's really more about, like, if a guy's not tolerating external rotation, maybe giving him some positions of, like Nolan kind of touched on, just some different positions where maybe rotation's a little bit more neutral, and we're just working into more some of that like horizontal abduction, just getting them, to start to get into a position where maybe that, that humeral head wants to glide anterior, and, they're not really tolerating that position back in, abduction and external rotation. Or just even getting them just beginning to weight bearing in like crawling positions, quadruped positions, moving into some push-up positions, starting even if, it's not a full range push-up, but just slowly getting them to tolerate more and more. While there's obviously a little bit of rotation going on, it's not going to be as intense as trying to get them, in like a 90-90 external rotation where, they can't really tolerate that position yet. So just finding ways of positions where we can get into more range of motion, in some weight-bearing positions that can begin to allow them to tolerate that. And then, like you said, just making sure we're, taking care of the rotator cuff and some of those posterior muscles to make sure that, those are strong and are helping them tolerate the positions.
Yeah, Scott kind of beat me to it. I think if you don't get your athletes, and I don't care if it's a thrower or if it's a soccer player, if you don't get them into close kinetic chain positions to challenge, especially their lumbopelvic control, core stability, as they're working through a lot of these motions with an extremity, I think that you're missing a massive piece to it. On our long rehabs, our TJs, our shoulder surgeries, something close kinetic chain like a wide balance is something that we use as a benchmark for progression into some exercise. Some of your surgeons still don't want kids lifting until, in my opinion, too long after a long surgery like that. So like a Tommy John, they don't want them lifting until sometimes after like 16 weeks post-op. And I think they're missing a big opportunity. We've got a lot of research that says if you work the contralateral side, with intensity, that you can maintain some strength on the ipsilateral side, which is always fascinating. But being able to work in close kinetic chain is an absolutely massive component of, especially the initial phase of trying to get an athlete more comfortable in a more provocative position, neurologically getting the shoulder to be in a stable position in that close kinetic chain exercise is so powerful, because then you can start to work into the more provocative position. And at this time of year, it's always funny. You start seeing social media posts and things like that. That always, it's like somebody must have been reading your mind, right? But I think when you see enough throwers, we all start to see the same injuries walk into our clinic, depending on the time of the year, right? So that early part of the year like this, obviously pretty early for you guys up north. Here in St. Louis, we've had kids now for a better part of a month, kind of starting with their high school practices. But boy, the anterior shoulder pain comes in a lot this time of the year, and getting them to be in a more optimal arthrokinematic position where we aren't in either a scapular anterior tilt or humeral anterior glide position, like you were saying, Max. The ability to basically perform the second part of that anterior apprehension test and provide that posterior inferior glide. We want to get them in that position to begin their rotation. So exactly what you were saying, maybe closer to that scapular plane, not as much in that provocative position of horizontal abduction. But that's why I like those positions where we got more of that body in contact with the surface to provide that more kind of proprioceptive environment, to where they can then focus on the exact arthrokinematics that we're trying to achieve, which a lot of times we all deal with probably the same. The vast majority of our caseload is a similar level of athlete, that high school into college athlete. Even our pro guys that come in, it never ceases to amaze me, some of the things that they can and cannot do as people that get paid to throw baseballs for a living. But getting them to understand that position first, and then slowly working through it, building upon it, to get them to the point, like Scott touched on, where we can actually begin what we would call some strength training, or communicate with the strength coach that is doing that strength training, has been really, really powerful so far. But I think it's something that is really missed, right? It's just a lot of times about checking a box that, they're able to have a 5 out of 5 MMT, and we don't even, we can get into dynamometry and things like that versus MMT, but allowing them to understand what the position and how to rotate the shoulder in the socket without getting into that anterior glide is a massive component. I think is something that maybe not everybody focuses on enough.
And you talked about not adding lifting for too long after Tommy John surgery. It brings up an interesting quote from one of my professors in PT school, probably like my first or second year. But the quote was, "If you're comfortable following a post-op protocol exactly, you better also be comfortable with not getting very good results." And so, it's very true. But we also get these scripts like we're talking about earlier, which is it's GIRD. It's a glenohumeral internal rotation deficit. And, my thing is that, yeah, we certainly see it, but it can be handled very, very quickly, especially in our young guys. And what we had kind of talked about online was, let's start with just our assessment. Let's look at the total range. I love that concept and that idea, because you can get an idea of potentially how much of a change to the actual bony structure we've gotten. When I talked to Garrett Bullock, who does a lot of research on this very thing, but he's a very prolific researcher. His thing was, hey, 5 to 10 degrees in most of your guys is what you should see as far as a deficit in internal rotation. And I'd go as far as to say, and tell me what you've seen with some of your research, Nolan, but I would go as far as to say that any thrower's got to have at least 60 degrees of internal rotation just to access the follow through or the deceleration pattern of the throw effectively. And then we can start to look at, okay, if they have 60 degrees, they probably have sufficient range to access the follow through and deceleration aspect of the throw without running into the end of their range of motion. Some of the research I've seen says that guys will go through about 45 to like low 50s degrees of internal rotation range of motion at the end of their throw. But I don't want them to slam into that, at the very end. So
yeah, and you got to figure that if they're the biggest thing with me and what we've seen, and we've seen some of our college guys that are, they're low 90s, mid 90s guys that, in my opinion, and this is one of the biggest changes we've made with one of our guys last year, that we're fortunate that we have Premier Pitching and Performance here in St. Louis. So they're one of a few facilities in the country that have a motion capture system like SEMI, where we can get some pretty objective data on how much these guys tend to access in the throwing motion. From conversations with those guys and then anecdotally in clinic, honestly, if I get a thrower or more elite throwers, if they're around 50 degrees passively with the scap stabilized into posterior tilt, and then they have that prerequisite shoulder external rotation in range somewhere around the 120, 125 when we've got guys in the correct positions, I'm usually okay with that, because if they cram into too much shoulder internal rotation in a delivery, or they access it, you think about where they access that kind of in-range internal rotation in the delivery, it's fairly far from that position that we measure them in clinic, right? So we aren't even really necessarily measuring them in clinic when we get a total arc range of motion in the same place that they get it in their throwing motion. So if they're cramming into a bunch of internal rotation too early in the delivery, then we start to think about, okay, is the shoulder then not following the same plane of rotation as the torso, right? Are they getting that? Mr. Nyman is the big one. He likes to get credit for this because he was one of the first ones that popularized the term. But if we're getting the kind of merry-go-round torso with that Ferris wheel arm, then they're not matching the same planes of rotation. So if we get shoulder internal rotation too early in that follow-through, or we get our quote-unquote in-range internal rotation too early, then to me, that's not even the problem, right? Our job here for all three of us is to mirror our physical exam and our physical rehab with mechanical too. And knowing and understanding where the athlete gets that in-range internal rotation at, as opposed to where we're seeing it on the table, that's where I become more comfortable with that kind of 50-degree-ish range, depending on what their external rotation flexion looks like. Again, that's anecdotal for me. I know the research is still right around the 180, 181 total arc from some of the stuff that the Champion Sports Medicine group did. But anecdotally, if we're total arc kind of 170 plus, I usually, if they have some sort of issue, elbow or shoulder, I'm going to continue to look across the kinetic chain somewhere else or at the delivery itself.
Whenever I assess the internal rotation of an athlete, I want to make sure that I've done it with a thorough process, or the most thorough process possible. And so I look at total range, but I think one thing that I do differently, and I don't know if you guys are doing this at all, but one thing that I do a little bit differently, and this was from my mentor, Ed, was you got to look at just passive resistance-free motion first. And so it's like, let it go completely floppy. And I see a lot of stuff on the internet where guys are cranking them and saying, okay, what's their actual full end range? What's that last stop? As opposed to what's the first stop, because that's the pathway of least resistance. So I'll start there. And then if I see like
this guy just doesn't go as far, you could end up seeing soft tissue limitation. You could see guarding. You could see a capsular limitation at that point. So then what's your next step? And my next step is I take them right to the end of the passive resistance-free motion, and then I give them a posterior glide. I give them an inferior glide, and I do my joint play at the end range, which is what I very rarely see done. Because my point is, hey, if you're doing your joint play in the open pack position, you could say, okay, this guy has a lot of posterior glide, and honestly, I've seen some of the most popular PTs in the baseball world, and they do their joint play with no stabilization of the scapula, so they're getting shoulder complex motion all over the place. But it's like, all right, so let's stabilize the scapula and then not do it in the open pack, and then that's fine, you can do it there, but let's also do it at the end range, just passive resistance free. I'm not giving them overpressure, and then I give them an inferior glide, and I should feel if it glides or not. And then if the left side gets further, great, it gets further, but I still assess at the end of the passive resistance-free motion. And if I feel this side glides and this side doesn't glide, then I have some indication that maybe there is some capsular limitation. So then the next step for me is let's do some contract relax, because we shouldn't see any capsular, we shouldn't see any change in range of motion if it's really capsular. And if these guys do some contract PNF, contract relax at end range, and the range of motion increases, then we're certainly dealing with some soft tissue stuff there. So that's kind of how I start to go about it, and from a very procedural kind of one step after another type of thing. And a lot of people are still assessing their internal rotation, like you talked about earlier, Nolan, where they're not actually stabilizing the shoulder complex or the scapula. But if you find that you can't get an inferior glide at the end of the passive resistance-free motion on the throwing side, and you can get it at the end of the passive resistance-free motion on the other side, then you're looking at something that's not gliding and sliding properly, especially if you are in tune with the face of the glenoid and not gliding it right into the labrum.
Do you see that at different ages? Different ages, you notice.
I'm sorry?
Do you see that at different ages, that your different ages you're starting to pick up on more of the capsular limitation as opposed to it being a soft tissue restriction?
Yeah, I do. I would say my college guys, I'll see it a bit. Pro guys for sure. I mean, sometimes in a high school senior. I don't really see it younger than that. But, I mean, my point is this. It's like I'm already in the position. If I see that, I'm gonna confirm my finding with some contract relax, and if I don't get any sort of improvement with contract relax, it's not going to be a soft tissue limitation. I'm either at the end of their arthrological range, just anatomically, or I'm at the end of their capsular range.
Yeah, I love that. That's a great stepwise progression as to determine if it's capsular, if it's soft tissue, and then you made a really good point too. And it's not necessarily something that I say that I document per se, but in the for our physical therapists listening out here, getting them to that R1 position first, and then understanding, okay, there's where our first bit of limitation is, and then getting into that R2 type position where, okay, that's our actual joint end range, and playing with the joint play at those positions will give you a pretty powerful idea as to what may be contributing to the limitation of the capsule. I think you guys do it up there. We do it here, soft tissue wise. It's obviously a lot easier to take care of than our joint stuff with the modalities that we have, like dry needling and all the manual soft tissue stuff that we can do. And it makes sense if you look at, and I haven't taken a course yet, but the concepts that they use, I think, are very, very applicable to our overhead athletes. But it's essentially what like an FRC system does, right? Where they get a lot of that, contract, relax at those various points in the range of motion to give that system a little bit of an input to improve that range. So, again, I that stepwise progression that you use, I think, is fantastic.
Now, Scott, on the on the other side of things, on the performance side, I mean, I know I was doing some things I probably shouldn't have been, but before I was even in PT school, if I saw a guy come in and his shoulder was stiff, I'm stretching his shoulder, moping his shoulder, or whatever. But kind of, what are you doing as far as you're going to see guys after therapy? You're going to, and it's tough, obviously, when you're dealing with remote guys, but you're going to see guys after therapy. You're going to see guys that never went to therapy, and maybe they didn't get the best care when they were in therapy, and they're going to have some deficits in range. They're going to have these different things. What are you starting to do to manage some of that stuff?
Yeah, yeah, I think just getting that good assessment and seeing where they're limited, and then just slowly starting to use like load as my modality of just whether that's just an isometric at end range against gravity, as like an early thing to just start to expose them, because I can't get hands on, and we're not just gonna only just passive stretch for hours on end and maybe not get a ton of change. So just if guys are limited in certain motions, just really trying to expose them to the opposite, end range positions, and then just like longer times of like isometric holds, and progressing along a way of if it really is there's maybe some anterior shoulder tightness with the pec, the lats, and things like that, maybe just starting with some push-up isos and then progressing into a little bit of a deficit there, to really get the pec, along with, like I talked about earlier, using chest flies as an option, as some load, and then some things of even can they just like in a dead hang position, but can they then stabilize scaps down, and maintain that position without allowing a ton of that superior glide, and just really just like finding positions to load, and then to help them move better by spending some time there and letting the tissues adapt, without having that option of, okay, can I get my hands on, can we do some soft tissue work, giving them some soft tissue work they can do on the sides, giving them and then integrating it into the actual lifting program, instead of saying like, oh, well, lifting's only for performance, or loading's only for getting stronger, whereas we can also use that load as our friend to improve range of motion and quality of movement, because they have to organize it within the task and under the load to execute that properly.
Yeah, that's an interesting point, because we've seen such a move towards loaded styles of what I'd call loaded stretching. The heavy loaded full range of motion, or even end range of motion type of stretching, which is something that's been used for years and years in the rehabilitation setting. It's just starting to be used in the performance setting. Where are you guys at with? So I know we talked about improving internal rotation range of motion with horizontal adduction across the chest, which I'm a huge fan of. Where are you guys at with the sleeper stretch and prescribing it?
I'm not a big sleeper stretch guy. Now I will say I love the active range of motion sideline internal rotation exercise that you guys have done up there. I think that's not an apples to apples kind of thing when it comes to sleeper stretch versus that. I think that we just end up cranking on the joint. Most of our athletes, I don't feel the stretch in the appropriate spot anyway. I think they feel a lot of times end up complaining of some anterior sensation rather than posterior aspect of the shoulder. I think that we end up throwing itself is going to be really hard on the joint. Why am I going to crank on the joint and make it even more provocative? So been a big horizontal adduction, shoulder flexion kind of person. You think again, if you go back to why is it stiff? I don't think sleeper stretch is going to do anything positive to the capsule either. So if it's a capsular issue or if it's a soft tissue issue, we have other ways to achieve more shoulder internal rotation than putting the joint in. Literally a test that we use to differential diagnoses of shoulder, or that orthos a lot of times use to differential diagnose of shoulder in the Hawkins-Kennedy test. I mean, we're impinging the shoulder basically. So educating the athlete on why or why not we do it is the first step. But I personally don't use it. I'm fairly anti-sleeper stretch. Now, I'm sure there's certain instances where it's like, all right, well, we feel like shoulder internal rotation is part of the reason that you're having the symptoms you're having. We haven't been able to achieve it any other way. So heck, let's go ahead and let's try it. And then educating them on the proper position to be in. I mean, we've had, in Missouri, we still don't have direct access. We're one of 3 states that don't have it. So, yeah.
Oh,
It's
wow.
awesome. So we've actually we've had doctors in our market pull patients from clinics for not doing the sleeper stretch. So
Wow.
it's been interesting. Fortunately, I have not had that yet personally. But again, we've had clinicians that are fantastic clinicians that do a great job with overhead athletes that have been like, yeah, they've shot me a text and you'll never guess what just happened. Got a patient pulled because I wasn't doing the sleeper stretch, and the physician literally cited that as the reason because they felt like they weren't listening to what they were saying, and so it takes even more education to the docs that refer us to patients too as to why we're choosing the interventions that we're choosing. It just comes down to communication.
I have to say, probably 2 of the top 3 most difficult shoulders that I've had to rehabilitate were posterior capsule releases, surgical posterior capsule releases. I don't know why they were indicated, but they got done and they ended up seeing me. So if that speaks to the importance of the posterior capsule and why we need to be very careful with our stretching of it. And that's been my contention. A lot of people have had contention with mobilizing the shoulder. My contention has largely been with mobilizing the wrong aspect of the capsule, mobilizing the posterior capsule when a lot of times we see an inferior capsule deficit. And it's very different when you're dealing with a 50-year-old rotator cuff repair than when you're dealing with a athletic shoulder. So that's been my contention. Is may not be that we always have to not mobilize the shoulder, and our mobilizations don't always have to be to the arthrological limit, to that final stop. Sometimes they can just be to that first stop to kind of center the humeral head a little bit while we take them through the range of motion. And that's what people don't realize. People think of shoulder mobilization, they think of crank it till you can't till you can't glide the shoulder anymore and then take it through the range. And it's like, hold on a second. I can take it halfway there just to make it more comfortable for them to get into the position.
Well, and you think about why, if you get a diagnosis from a doc and it talks about, posterior capsule stiffness and things like that. Well, what kind of pain is the athlete having? They're probably having anterior shoulder pain, right? So the question becomes, why are they having anterior shoulder pain? And more times than not, it's going to be a lack of control of shear. And again, where does the shear come from? It is probably an underperformance of your subscap, rather than just strictly going to stiffness in the posterior shoulder musculature capsule. I would rather go first to, am I going to take care of any soft tissue limitation we find in the posterior shoulder? Absolutely. But I want to make sure that they can use their subscap to control proper arthrokinematics of the shoulder throughout its entire range. And so the sleeper stretch would be something pretty far down the list as to something that I would use to achieve whatever our end goal is.
Yeah, I'm glad you said that about subscap, because I feel it's the most overlooked in especially shoulder rehabilitation for athletes, but even my elbows too. They have to be able to eccentrically control external rotation as they go back, and if you're just ignoring the subscap, you're going to run into some issues. Yeah, we got to clear the lats and other things like that. And we spend some time trying to, at my clinic, we spend some time trying to turn off the lats and train the subscap and isolate it initially, and then do some work where it's not so specific and isolated. But if you're not training internal rotation and you're not training the subscapularis, you're missing out on one of the most important things. So I'm glad you brought that
that's
up.
even soft tissue quality and trying to get in and restore soft tissue quality of the subscap when it comes to performance of that muscle. We can't just load it with exercise. We have to actually assess what the soft tissue quality is, and that's where, again, dry needling is a really powerful tool for us to use in some of those trigger points that we see, in the subscap, and that's been something in the last 3 years or so with utilizing dry needling that's been really, really helpful. Obviously you have to be careful just because of the lung field and things like that, depending on the size of needle that you use. But even just getting them into a little bit of an abducted position and getting your fingertips on the anterior surface of the scap is something that's very, very powerful from a hands-on manual therapy perspective.
Yeah, huge. Scott, what do you do as far as assessing guys remotely? Because I'll work with guys remotely too. It's a small percentage of what I do, and it's usually people that aren't able to travel here. But what are you doing to assess them? Are you on a live call? Are you doing? Are you saying, hey, here's what I want you to video, kind of a screen? Because it does make it much more difficult if you can do remote. If you can do remote assessments, I mean, in-person assessments.
Yeah, for sure. It's definitely a little challenging, but I typically have guys, I kind of send them some things that I want them to record them doing with a specific angle so I can see what I would like to see. So kind of just going through some shoulder motions, so it's going to be a lot of active stuff of just like, how do they get into shoulder flexion, shoulder abduction, and, and then as well as, trying to see how the scaps are moving. I'll have them do kind of like put them at a corner of a wall and half kneeling at the 90-90, do kind of an external rotation lift off, mostly to kind of see how they get into that position. I've had guys send me a video and the only thing they do when they go to do that position is arch their back, and none of it actually comes from their shoulder. So just really like looking at that, some of those motions, assessing how the T-spine's moving, some T-spine rotation, things like that, just in some videos, and then as well as seeing how they move under load. What does a bear crawl look like for these guys? What does a push-up look like? And how do they respond under some of those things like that? So that's kind of how I do it, is just kind of looking at some active motion, how they're moving about it, and then how things change under some loaded positions that I know will be tolerable right away, or at least not too provocative of like a bear crawl or a push up or something like that.
What do you guys do?
One thing that I've
what do you guys
what was
do
that, Nolan? A little delay.
To differentiate between kind of your mobility versus motor control stuff with some of those remote athletes? Because that's got to be something that's a little bit of a challenge, right?
Yeah.
I think for me, I'll probably attack it with a little bit of both. Like if I notice a guy doing shoulder abduction, something looks a little goofy with the scap, into upward rotation, then maybe that lat's a little tight, maybe some of those, maybe that's not moving correctly. But just to be sure, I don't think it's going to hurt to give them, all right, here's an exercise, a little bit more motor control, here's a little bit of a mobility exercise, and then we can kind of see how they respond to both of them and see where the progress is going. Because it can kind of be tough of like, okay, is that, because I can't really then get on it and feel like, if I give some overpressure to guide the scap, or, is it just their movement? Like, can they get there, or is it really a tissue restriction? So maybe just giving them a little bit of both.
Yeah, you have to do a little bit of guessing, I think, too. Like, you're looking at how he moves in the other assessments and saying, all right, does this look like a guy that has some hypermobility? Does he look like a guy that's just grossly stiff? That's at least how I go about it. And I like kind of, hey, let's hit it with the end range control. Let's hit some lat lengthening stuff. Let's hit some periscapular strengthening, kind of hit all of those things. I like that. One thing I've found effective is just having guys go through the exercises that they're going through. Like, let me see the exercises that you've been doing in PT, or take a video of those. And I'll see people, the most common one that I see for people that are reaching out to me from a remote standpoint that are kind of failing PT is they have anterior shoulder pain. They're usually someone that's got some instability, and then they end up doing external rotation like this far. Like they're like, and it's like, hold on a second. This is, and they're like, yeah, I walk out of there and I have a 7 out of 10 pain. It's like, well, why don't we just start to get strong right here, and then we can maybe progress a little bit. But it's like, that's the biggest one I see, and I'm sure you're seeing people in a little different light from a remote standpoint. But most of my remote clients are people who are failing PT or conservative treatment or rehabilitation somewhere in the country, and then they're sending me videos, and they have anterior shoulder pain, and they're going through huge ranges of motion, and it's like, no wonder you have anterior shoulder pain. You just put yourself in a horrible position 100 times during your exercise routine. And then you get them to just control the range and stop at a reasonable point for where their shoulder's at, and all of a sudden they don't have pain anymore.
Well, and you can bet that if they're doing that, their exercise, that their throwing motion's going to have some anterior shear control.
Yeah, exactly.
You know, there's some issues with anterior shear control too. So, yeah.
Do you do any remote stuff, Nolan? Or are you
I haven't.
all
Anything that I do via video is with kind of some local pitching coaches. You know, that's kind of one of my big roles in the St. Louis market is to essentially kind of consult for some of our local pitching coaches, which is awesome. You know, I get to see the whole range of athlete age groups from your 11U kids all the way up to the pro guys that we have here in the off season, and those pitching coaches are a massive reason as to me having any sort of knowledge of pitching mechanics. It's through conversations with them. They've been extremely generous. I've gone in, watched lessons with them, had conversations at all hours of the day and night with them about mechanics and their philosophies. And I felt like for me as a clinician, seeing athletes from across all of their academies, that I needed to know the cues that they use, how they coach, what they like to see, to be able to make sure that our communication is as efficient as possible with the athlete. So anything I do remotely, I don't officially see patients on a schedule remotely. We have the ability to do that via Zoom if we need to, but I prefer to have them come here when they can, and we've had them come from St. Louis, so we've had them come from Kentucky, parts of southern Missouri, so we've seen them for quite a distance, maybe not the distance that you've seen guys from Madison. And obviously, Scott, you're going to be getting into that clinical practice realm. You'll probably see from your remote business that you've built up, you're going to see them from all over the place. So I don't quite see, as far as remote goes, Dr. Aaron Borshig, Squat University, is one of our clinicians here at SSM. So when he has the Indian national weightlifting team in town, I think he takes the cake. It's the farthest distance traveled for a remote to in-person.
Yeah,
so he came out with us.
That's cool.
Probably between 16 months and then 2 years ago, somewhere in there. And so he works at a really cool clinic that we have, and does a fantastic job for us. So,
is he far from you then, or is it?
We have over 80 clinics.
Okay,
yeah,
so
we have
got a
80
bunch in
some
that
clinics
area.
in the St. Louis area. So we're a hospital-based provider, and that's my opportunity. Again, I can't say enough about the opportunity that I've had here. I came in kind of with an idea when I graduated in 2017 of how I wanted to practice, and they were very forward-thinking and basically was like, okay, well, how do we get it done? And so I get to see about 75% of my caseload is baseball kids, baseball athletes of all ages, which is maybe a little more unique when it comes to like a hospital-based outpatient ortho type place. Most of your day in a normal setting for that hospital-based outpatient ortho is your 2:30 in the afternoon on is your kids. But I'm fortunate that we've got quite a few JUCOs and four-year universities in the area that I get to see from. Yeah,
that's awesome. So we've taken a lot of time here, and I know you guys are very busy. So, last thing, do you guys have something you want to leave the listeners with? We've hit a ton of great points here. Scott, you want to start?
I think one point could be important with the seasons ramping up for a lot of high school guys is, and I think Max, we even had a small conversation about this on Twitter of just, at some point during the season, you're probably going to get some soreness. You might get a little bit of a spike in something that's new. I don't like the first sign shouldn't be to freak out and go rush and try and get an MRI or a diagnosis with just the sign of some soreness or a little bit of pain. Just give it some time, maybe calm it down a little bit, maybe take an extra day before your next high intensity throwing day, make sure you're sleeping, getting good nutrition, hydration after games. And then if it begins to linger, then go see someone, get it looked at, find the, root of the problem. But, it's just from my time doing some stuff back in person this year, and guys found out that I'm in PT school. As soon as they feel one little thing, they're running up to me like, hey, what's wrong? What's this? Pointing to this. Hey, what's this? Can you tell me what to do? Like, what stretch can I do? What, can you work on it? Whatever it is. So I think, sometimes baseball players can be a little hyper focused on their arms and hyper aware to where it's not that, not everything is, pathologic or a problem that needs to be attacked right away. Maybe it's just workload. Maybe it's just you didn't sleep well the night before. So just, keep that in mind as the season goes on for any athletes listening that, when it's a problem, but don't make it a problem before, it kind of becomes a problem.
That's
Yeah,
awesome.
Love it.
How
about you, Nolan?
And you, Max, you and I have had this conversation before via social media. I think kind of for our clinicians out there, don't discount the importance of kind of your central stability and what effect it has kind of up the chain. Like we touched on before, make sure that you get your athletes in some sort of closed kinetic chain position, both in your evaluation and then spending that time in treatment, especially if you see that population of athlete, the younger, little league into high school, helping them command the center of their body is only going to help them athletically in every aspect of what they do. And I think we tend to still in our field, despite social media, despite all the research that comes out, we tend to go too distal too quickly. And I think, Max is gone, lost it. I think that we end up we lose too much of our focus on the center of the body.
Yeah, I love that. I think I probably do myself, so I know that people out there listening will find that, especially the closed kinetic chain stuff.
Yeah, and that's the biggest thing we see with hip mobility stuff. Yeah, we see like hip mobility. I think we spend too much time in open kinetic chain versus helping the pelvis move on the femur. So.
Yeah, definitely a great takeaway there too. Where can we find you guys? I know you're Rich Rehab. That's an easy one. Scott Richardson's Rich Rehab on Twitter. And I think you're Rich Rehab. Is it Rich Rehab Performance?
Yeah. So Rich Rehab on Twitter, richrehabperformance.com for my website, and then also just Rich Rehab Performance on Instagram.
Yeah, I'm more active on Twitter than I
Nolan?
am Instagram. Hopefully that changes. I just need to post a little bit more on Instagram. I'm at Nolan_Rappé 15. So first name _ last name 15 on Twitter there. And like I said, I have way more interaction there than I do on Instagram. So come find us, chat.
Rappé is
Yep.
Rapppe.
Yep.
Rapppe. Alrighty. Thanks for coming on, guys. This was a great podcast. In the name of Over at Athletics, I'm Max
Thanks,
Wardell, signing off.